The skull is the most complex structure of the axial skeleton, and it is composed of a total of 22 bones. There are 8 cranial bones that form the rounded cranium that completely surrounds the brain, and there are also 14 facial bones that help to form the structure of the face. Let's quickly take a little tour through these different bones. Among the cranial bones, there is a single frontal bone at the most anterior part of the skull, 2 parietal bones on the most superior, 1 on each side. The occipital bone is a triangular shaped bone in the back most posterior part of the skull. If we look at the lateral views, we can see the 2 temporal bones, 1 on the left and 1 on the right. There is a single sphenoid bone, most of which is located or is visible on the interior part of the cranial cavity, so we'll get a better view of that one later. And then a single ethmoid bone, which is also a little more difficult to see from this external view, but we'll be coming back to that one as well. As for the facial bones, you have a single vomer in the middle of the nasal cavity, 2 inferior nasal conchae, 1 on either side of the nasal cavity, 2 nasal bones, 2 maxillae, a single mandible, two zygomatic bones, 2 small lacrimal bones, and then the palatine bone, which can only be seen if we remove the mandible and look at the roof of the mouth. We are not going to spend a great deal of time in this video going over the individual bony markings of all of these bones, so I strongly recommend that you view the video for lab lesson number 20 on the skull before continuing on in this video. I do want to take a second to note that because of the three-dimensionality of the skull, it's very difficult to truly appreciate the shape and size of some of these features strictly based on the images that are in your textbook and in your lab manual, especially because many of those are at direct 90-degree angles. I've provided you with a handout that you can print out that includes some additional external views of the skull, such as you see here, as well as some internal ones as well. I'm going to recommend that you print those out and label them as we go along, and you can print out multiple copies in case you'd like to label some with bones and sutures, for example, and others with bony markings or sketch on muscles, or whatever you like. I just think these images provide you a slightly better perspective. We're going to start by talking about some articulations. Hopefully this figure looks familiar to you by now. This includes our classifications of joints into fibrous, cartilaginous, and synovial structural classifications, and their subclassifications as well. The immovable joints that form articulations between the flat bones of the skull are known as sutures. So let's take a few minutes to go over the cranial sutures that you're responsible for in this class. The sagittal suture is the articulation between the left and the right parietal bones, and you'll notice that that is in the sagittal plane of the body, hence its name. The coronal suture is the articulation between both of the parietal bones and the frontal bones, and you'll notice that that one is in the coronal plane of the body. The lambdoidal suture is the articulation between the 2 parietal bones and the occipital bone, and if you were to look at this directly from a posterior view, it would look like an upside down V, or an upside down Greek letter lambda, hence the name. And then finally the squamosal suture, which is the articulation between the parietal and the temporal bone. On the interior, the skull is divided into several different cavities. There is the cranial cavity that encloses, protects, and supports the brain. And then the skull also has several smaller cavities. The orbits are basically the eye sockets, the oral cavity or the mouth, the nasal cavity, and then also the paranasal sinuses. We're going to begin by talking about the cranial cavity. So the cranial cavity, as I said, includes all of the bones that enclose the brain, and I've highlighted them all here for you. So let's pause for a second, go ahead and give yourself a little bit of a quiz and see if you can remember what the names of these bones are that comprise the cranial cavity. All right, so let's start with the red one. Hopefully you've identified that one as the frontal bone, the blue one as the parietal, the occipital bone, the temporal bone, the sphenoid bone, and parts of the ethmoid bone as well. So those are the cranial bones that are going to completely enclose that cavity, and you should be able to identify those from an external or an internal view as we have here. If we were to look at the floor of the cranial cavity, we can see that it's actually divided into 3 different fossa. Remember that a fossa is a depression in the bone. And if we were to look at the floor of the cranial cavity, we can see that it contains an anterior cranial fossa, a middle cranial fossa, and then also a posterior cranial fossa. And though it might not be incredibly obvious from this perspective here, if you look at the sagittal view on the left, you can see how there actually is quite a lot of depth to these. So it's not a flat floor. The anterior cranial fossa is going to house the frontal lobe of the cerebrum. The middle cranial fossa houses the temporal lobe of the cerebrum. And then the cerebellum is housed within the posterior cranial fossa. The other thing you can notice in this posterior cranial fossa is the giant foramen magnum that the spinal cord leaves through. In the lab video that's associated with this lecture, you're going to see a very thorough tour of all of the foramina and features that are on the floor of the cranial cavity. For now, the main one I want to point out is this boundary line here between the middle cranial fossa and the posterior cranial fossa, and that's referred to as the petrous ridge. There isn't a specific name for the division between the middle and the anterior. I want you to think about this as being kind of the ridge of a mountain, and again, if you were to look at the sagittal view, you can see how it is kind of peaked up there. And underneath that is where you're going to find all of the structures of the inner ear. So let's take another quick little look at the floor of this cranial cavity. I'm going to cut this skull along a transverse plane, and now you can get a slightly better appreciation for the depth of this and the real three-dimensionality of it. You're going to get a complete tour of all of the structures that you can see here, especially all of the different foramina in the lab lesson that's associated, in the video that's associated with this lab lesson. So on to the rest of the cavities of the skull. Next we have the paranasal sinuses. And paranasal sinuses are air-filled chambers in the bones of the skull that open into the nasal cavity. There are 4 distinct cavities that make up the paranasal sinuses. The frontal sinuses that are located within the frontal bone, superior and medial to the eyes. The ethmoidal sinuses that are located within the lateral masses of the ethmoid bone. The maxillary sinuses are found within the maxillae, and these are the largest sinuses. And the sphenoidal sinuses are located within the body of the sphenoid bone. These paranasal sinuses have a mucus lining that helps to humidify and warm the inhaled air. It also causes these skull bones to be lighter, so that's less weight to support, and they do provide resonance to your voice, which is why your voice changes if your nose is stuffed up, if there's swelling and less volume in that cavity, because it alters the resonance of your voice. This image here is showing you a coronal cut of the skull and points out several of these sinuses. You can see the maxillary sinuses right in the region where you would kind of think about your cheeks being. You have the ethmoidal sinuses that are in those lateral masses of the ethmoid bone. You can see a few little bits of the 2 frontal sinuses here, and the sphenoidal sinus is even deeper than this cut, which is why it's not visible here. So now let's move on to the nasal cavity. The nasal complex consists of the bones and cartilages that enclose the nasal cavity and also the sinuses that are around them. The superior border, which you can see right here, consists of the cribriform plate of the ethmoid bone, parts of the frontal bone, and also parts of the sphenoid bone. The inferior border consists of the maxillae and the palatine bones. And on the lateral side, you can see portions of the ethmoid bone, more part of the maxillae, the inferior nasal conchae, and other parts of the palatine bone, and then you can even see a little bit of the lacrimal bone here. The orbital complex includes the cavity formed by the bones that line the orbit and that protects the eyes, and also the muscles that attach to those bones and move the eyes. I don't want you to be concerned about naming every bone that happens to be part of the orbit. Just look inside the orbit and you can see what bones are going to be there. So you can see here in red, we've got a portion of the frontal bone. In purple here, the sphenoid. On the medial wall, you can see part of this maxilla and a little bit of the lacrimal bone here, and a small bit of the ethmoid bone. On the lateral wall, again, you can see some of that frontal bone, the sphenoid bone, and the zygomatic bone. And then here on the floor of it, you've got primarily the zygomatic bone, the orbital surface of this maxilla, and also just a small little bit of the palatine. We'll be discussing the muscles that attach to these bones and move the eyes in a latter part of this module when we talk about the special senses. The skull also contains a few other composite structures that are built from markings of multiple bones. One example of this is the zygomatic arch. Each zygomatic arch consists of the zygomatic process of the temporal bone and the temporal process of the adjacent zygomatic bone. If you were to put your fingers on the bony prominence of your cheeks and then just move them posteriorly towards your ears, you'd be running your fingers along your zygomatic arch. The maxillae and the palatine bones make up the hard palate, which forms the roof of your mouth, as well as the floor of the nasal cavity. And specifically, you're going to see that in each palatine bone, there is a horizontal plate, and on each maxilla, there is the palatine processes. So really, there are four individual bones that comprise the hard palate. And then finally, the bony nasal septum consists of the vomer, which you can see here in yellow, and then the perpendicular plate of the ethmoid bone. You may have heard of the term deviated septum before, and that is specifically referring to a nasal septum that is off-center or crooked. So here you can see a sagittal view of that nasal cavity, and this kind of off-whitish color is meant to represent bone here, while the bluish color is cartilage. So you can see here's our perpendicular plate of the ethmoid bone, and then we have our vomer, and then these two bones in combination with this nasal cartilage help to form this nasal septum. This image here is showing you of what a picture of a moderately deviated septum would be. So you can see how it's crooked in this case as opposed to the straightened version here down below. So what happens when you have a deviated septum? There can be obstruction to the nasal passages in some of the more severe cases. It can also lead to congestion and recurrent sinus infections. It can disturb your sleep because of this obstruction in the respiratory tract, and it can also cause nosebleeds. This can be treated, however, in some cases with medications, but depending on the severity, it can be treated surgically as well. You can see in two examples here. This one on the top part, this is a slightly crooked, slightly off-center deviated septum. And then here you can see an example of one that is a little more extreme, and you can see how the two nasal openings are much different in size based on that septum. And then this is showing the surgical repair over here on the right. It's thought that approximately 80% of people actually have a deviated septum, so the majority of them go undiagnosed because the deviation is so small, it doesn't really have any significant physiological effects. Most of the time, these deviated septums are caused either by an injury to the nose, or the majority of them are just the way you're born. The hyoid bone is the only bone in your body that does not articulate with another bone. It's located between the mandible and the larynx, which is your voice box. It provides an attachment site for the tongue, as well as for muscles of the larynx that are used in swallowing. Now back to some of our articulations of the skull. We've already mentioned the sutures. I do want to bring up, however, another fibrous joint that we haven't talked about yet, and that is a gomphosis. A gomphosis occurs between the alveolar margins and processes of the mandible and the maxillae. So if we look over here, this is looking at a tooth that is found in the mandible. All of the little ridges that you see here are referred to as alveolar processes, and the roots of the teeth fit into those alveolar processes. You can see several membranes that are present here that contain ligaments that hold the teeth together. As is true with other ligaments, these ligaments consist of dense regular connective tissue and help to hold the teeth in place. Now, the last time I taught this class, I had a student ask me why we have one set of teeth as children and then we lose that and get another set of the teeth that remains with us through the rest of our lives. And to answer that question, we have to actually take a little bit of an evolutionary perspective. Most vertebrates, including toothed fishes and reptiles, are referred to as polyphyodonts, which are animals whose teeth are continuously replaced throughout their lifetime. So for example, alligators are born with a full set of teeth, and each tooth is replaced approximately once a year. So any single tooth is replaced approximately 50 times over the course of the animal's life. Most mammals, however, are referred to as diphyodonts, or animals with only 2 sets of teeth. So why do most mammals only have 2 sets of teeth? Why aren't they continually replaced? While most extant mammals are not polyphyodonts, mammalian ancestors were. So during the evolution of mammals, there was a period during which they were so small and short-lived that wear and tear on the teeth didn't yield any sufficient selective pressures to consistently replace those teeth. But instead, selective pressures did result in mammals evolving different types of teeth, which then gave them the ability to crack the exoskeletons of insects and other arthropods, which formed a substantial part of their diet. Molars came much later in their evolution. There are, however, a few living mammals that are still considered to be polyphyodonts, and those are manatees, elephants, and kangaroos. Now, all of these animals don't have any incisors or canines, only essentially molars or premolars. And all of these animals also feed primarily on abrasive vegetation that is frequently mixed with sand. So if you look into this mouth, for example, of an elephant, you'll see all they have are molars. But interestingly enough, these molars don't fall out and have one replaced right in line with that individual tooth. They're actually on a conveyor belt-like system that's sometimes referred to as marching molars. So all of the new molars come out in the back part of the mouth, and then as new ones come in, they push the rest of the molars further forward so that by the time you get to this front part of the mouth, those are the oldest teeth, and that's where they fall out. And so that type of marching molars or conveyor belt replacement model exists in manatees, elephants, and kangaroos, and those are the only living mammalian polyphyodonts. All other mammals are diphyodonts that only have 2 sets of teeth in their lifetime. The last articulation that I want to talk about with the skull brings us back to our synovial joints, which we've spent a lot of time on, and that specifically is the temporomandibular joint. This is an articulation that is formed between the condylar process of the mandible, which is also known as the mandibular condyle, and the mandibular fossa of the temporal bone. Now, this joint is structurally classified both as a synovial plane and hinge joint. This is the only mobile articulation between bones of the skull, and it has several unique features. One of which is a thick articular disc of fibrocartilage that actually divides the synovial cavity into 2 separate chambers. So this allows it to function as 2 separate synovial joints that exhibit both the hinge and gliding movements. There's also a very loose articular capsule that allows for a wide range of motion. However, this loose articular capsule can also create some problems, and you may have before heard of TMJ syndrome. When TMJ syndrome occurs, ligaments loosen and displace that articular disc, and that can cause problems such as popping or clicking when the jaw is being opened or closed. It can also lead to other symptoms such as headache, sinus pressure, pain in the ears and mouth and teeth, and so forth. This can be caused by things such as overly chewing gum, grinding your teeth, or in some cases just a misaligned bite. So here you can see in this figure that we've got a misaligned bite that is kind of pinching off this the cartilage that is part of that articular disc. And so over time, that cartilage is going to be misshapen and then pushed off to the side and displaced. So once that cartilage begins to deteriorate along one part of it, it can, in this case, it's allowing the jawbone to grind against the skull, or it can also allow it to slip out of that fossa into a place where it's not supposed to be. So the last thing that I'd like to talk about before we move on from skull articulations are the fontanelles. So fontanelles are the fibrous membranes between the cranial bones that haven't yet ossified on a baby's heads, otherwise known as the baby's soft spots, which you may have heard of before. So why are these there to begin with? Now, when a baby travels through the birth canal, the cranial bones are able to overlap at these fontanelles because they haven't fused yet, and this helps to ease the baby's passage. This is also why newborns frequently have a cone-shaped head. It's as a result of this temporary deformation. These fontanelles are named based on their locations. We have the anterior fontanelle that's between the parietal bone and the frontal bone, also known as the frontal fontanelle. The posterior fontanelle that's between the parietal bones and the occipital bone, and this is can also be referred to as the occipital fontanelle. There's the mastoid or mastoidal fontanelle between the occipital bone and the temporal bone, and this can also be called the posterolateral fontanelle. And then last but not least, there's the sphenoid or sphenoidal fontanelle that can also be called the anterolateral fontanelle. So all of these fontanelles have at least two different names to them. I am fine with you using any of those terminologies, any of that terminology during your assessments. This here is showing you a superior view of both an adult skull and a fetal skull. And so you can see a good example here on the fetal skull of that anterior fontanelle and that posterior fontanelle, but there's a few other features that you'll notice as well. Notice how the parietal eminences on a fetal skull are much larger and much more prominent than the parietal eminences on an adult skull. And in the fetal skull, there are also two frontal eminences that are barely visible at all on the adult skull. There is also one additional suture that's only found in a fetal skull, and that is actually present right through the frontal bone. While on an adult, you can't even see this suture. During development, there are actually two ossification centers in that bone, and those sections fuse at what's known as the metopic suture. And this suture will disappear completely by around the age of 2. So what about closure of the fontanelles themselves? The first fontanelle to close is going to be the posterior fontanelle, and that closes up at about 2 to 3 months of age, followed by the sphenoidal fontanelle at about 6 months. The mastoid fontanelle will close up sometime between 6 and 18 months, so quite a bit larger of a window there. And then finally the anterior fontanelle at sometime between about a year and a year and a half. Craniosynostosis is the premature closure or fusion of these cranial sutures while the brain is still growing. And one example is that of the metopic suture. We already mentioned that the metopic suture separates the two frontal bones at birth, and it's the first skull suture to close physiologically, and that happens at about 3 months and begins at about 3 months and is usually complete by the age of 8 months. So a premature fusion, however, will not only result in an obvious ridge over the midline of the forehead, as you can see here in this lower right image, but also in a lateral growth restriction of the frontal bones. So as a result, you're going to end up with a skull that has a triangular forehead and a kind of bony midline ridge. And this will also shorten the anterior cranial fossa, which is obviously not a good thing. During the first year of life, the brain triples in size, and a large portion of that is in that anterior cranial fossa. This here is showing an image of a child that had this condition. So as you can see here on the left, we can see that that symptom of the eyes being very close together, and then from the superior view, there's a very distinct triangular shape to the head. Fortunately, we are able to correct this surgically. These images here on the right are showing the images of the exact same child approximately 1 year after their FOA surgery, which stands for fronto-orbital advancement. An FOA is a surgical procedure that's used to reshape and then reposition the bones of the forehead and of the orbits. It's usually performed between 9 to 12 months of age in order to restore these normal contours to the affected areas. But they have to also account for the continued growth of the skull, and they do this by attaching the reshaped bones with dissolvable sutures and dissolvable plates. We've previously identified 5 groups of axial muscles: muscles of the head and neck, vertebral column, respiration, abdominal wall, and pelvic floor. And we've already talked about a few of those, but today we're going to focus again on some of the head and neck muscles, but specifically those involved with mastication, which is chewing and swallowing, facial expression, and then also neck movement. So muscles of mastication. These are muscles that are involved with the process of chewing and swallowing, as I said, and they help to move the mandible and work on the temporomandibular joint. All of these muscles are innervated by cranial nerve number 5, specifically the 3rd branch, or the mandibular branch of this trigeminal nerve. The muscle that you can see here that I've tagged in green is the temporalis, and the temporalis elevates and retracts the mandible, while the masseter, the one I'm tagging in blue, elevates and protracts the mandible. If we look over here on the right, we can see how the temporalis is going to originate along the temporal lines, kind of where I have this green dashed line, and then its insertion is going to be on the coronoid process of the mandible. So think about how when this muscle that is going along that direction shortens, then that's going to result in that elevation, but then also the retraction of the mandible. The masseter, on the other hand, is going to originate from the zygomatic arch and then insert into the angle of the mandible. And so then if you can picture this muscle here, when we have this this insertion at the arrow moving towards the origin at those lines, we'll still have that elevation of the mandible, but this time it will be protracting the mandible. So muscles of facial expression. These are all muscles that originate in either the superficial fascia or on the skull itself, and then they're going to insert into the superficial fascia. These muscles include the epicranius, which includes the frontalis and the epicranial aponeurosis, as well as the occipitalis that we'll see from the other end. And this is the muscle that is going to raise the eyebrows if contracted. There's the orbicularis oculi. Orbicularis is referring to orb or round, circular, and this is a sphincter muscle, so that the opening of the opening kind of in the middle of that muscle is going to get smaller when this muscle contracts. Oculi, ocular, that refers to the eye. So this is literally the muscle that is around the eye, and when that muscle contracts, it's going to close the eyes. The orbicularis oris, you can think about this as kind of like a puckering muscle. This is also a round sphincter muscle that goes around the mouth, and so when this muscle is contracted, you get this kind of puckering type of facial expression. The platysma tightens up the skin around the neck, like this very strange looking picture here on the lower right. And also the buccinator. The buccinator is a muscle that kind of compresses the cheeks, as you would if you were either holding food in place or if you were playing a wind instrument, for example. This is giving you a lateral view of those same muscles, but here we can get a better view of the occipitofrontalis, or the epicranius. So this actually consists of two different muscles, the occipitalis and the frontalis. So the frontalis is going to originate at that epicranial aponeurosis and going to insert into the skin of the forehead. So that's why when this muscle contracts, it's going to raise the eyebrows. While the occipitalis is going to originate at that superior nuchal line and then insert into the epicranial aponeurosis. So this one is going to be responsible for retracting the scalp and pulling the scalp posteriorly. And finally, muscles that move the head and neck. On the anterior and lateral sides, we have the sternocleidomastoid. This is a muscle that originates from the manubrium of the sternum, as well as the sternal end of the clavicle, and it's going to insert into the mastoid process of the zygomatic bone. So hence the name, sternocleidomastoid. Sterno, sternum, clado, clavicle, mastoid process. Now when this muscle contracts bilaterally, so when both of those, the sternocleidomastoid on each side of the neck flexes, they're going to cause flexion of the neck, as if your chin was being touched towards your chest. If only one of them is contracting, however, they're going to cause a lateral flexion and rotation of the head to the opposite side. So when your right sternocleidomastoid contracts, your head turns to the left. When your left sternocleidomastoid contracts, your head moves to the right. And I know that may initially sound a little counterintuitive, but I think this video kind of helps a bit. So this is showing you this a right sternocleidomastoid. And every time that muscle is in yellow, it's contracting. So remember that down here is the origin, and then up at this mastoid process is the insertion. So when this muscle contracts, like now, it's pulling that closer to it. It's pulling that mastoid process anteriorly. And so that's how you get that kind of opposite movement, so that when the one on the right side is contracting, the head's turning left and vice versa. The sternocleidomastoid is innervated by the accessory nerve, or cranial nerve number 11, which may sound familiar to you because we've already talked about that as being the innervation of the trapezius muscle. And finally, we've already mentioned them, but I just want to bring up again the splenius capitis and the splenius cervicis. These are muscles that do move the head and neck that we've already talked about. They're responsible for extending the neck when they're contracting bilaterally, and if they're contracting unilaterally, then that is going to help to rotate the head. These are going to be innervated by some of the cervical spinal nerves, and you're not responsible for their specific innervation in this class.